Good evening, esteemed members of our Maharashtra Ophthalmological Society, and also members who are joining us at large from our All India Ophthalmic Society. We welcome you to this very enlightening webinar on glaucoma today for comprehensive ophthalmologist. And this is today's webinar is as a primer for glaucoma drainage devices for our ophthalmologists all across India and Maharashtra. As the chairman of scientific committee, it is my honor to extend warm welcome to each of you. And we are going to delve into crucial insights, advancements, and discussions surrounding this one of the most important topics in glaucoma, and probably not so much. The comprehensive ophthalmologists are not so much aware about what are the current status of glaucoma drainage devices, what is the right indications for them, what is the current success for them, so that they can understand the nuances. For those surgeons who have mastered their trabeculectomies, can gather information how they can start valve surgeries, but at the same time, for those surgeons who are not actually performing glaucoma surgeries themselves, they will also know when to refer the patient and basically what to expect after they have referred the patient to the glaucoma expert as well. So your active participation is really going to be invaluable, all our members. And I sincerely hope that this session proves to be both informative and enriching for each one of you. First and foremost, I would like to now request the chairperson of today's webinar, none other than our president, very dynamic Dr. Santosh Agarwal sir. Dr. Santosh Agarwal sir is currently the president of MOS. MOS, as we know, is probably the largest state association in the entire country. He has been heading right from the beginning with a lot of invaluable and very dynamic new programs for our MOS. And it was his actually thought process to actually designate 1 month to one specialty. And this month we are going to actually cover glaucoma in terms of both postgraduate courses as well as webinars as well. So Dr. Agarwal sir is a well-known cataract and retina specialist. He is alumnus of the prestigious Shankara Nethralaya. And I would like to now request Dr. Agarwal sir to give his welcome address. Over to you, sir.
Thank you, Vardhaman, for your kind words. So, respected seniors and my dear friends, greetings and good evening to one and all. I welcome you all to this unique webinar on a new modality of glaucoma surgery, that is tubes in glaucoma. Also, at the outset, I wholeheartedly thank the experts, speakers, panelists to share their valuable time for this webinar. There would be a video presentation on glaucoma surgeries, the new modality of glaucoma surgery, followed by a panel discussion. So it will be more of an interactive session. I am sure we all will learn, including me, that this newer modality of glaucoma surgery with its inherent intricacies and nuances as well. I thank Vardhaman, Aditi, and especially Priti Kamdar ma'am for taking all efforts to curate this webinar in a very useful way. I request the audience and participants to please send your queries in the chat box or to Dr. Priti madam or Vardhaman or Aditi to make it more interactive. And I will conclude my talk with a one just quote. When you learn a little, you feel you know a lot. But when you learn a lot, you realize you know very little. So we have to learn a lot, and also we have to practice in our day-to-day our practices the newer things so that we can cater our good services to the patient. So thank you very much for your patient listening. Over to moderator, please. Thank you.
Thank you so much, sir, for your very nice welcome and very well said with the last quote. And we all want to learn more and more under your leadership. Thank you. So now I would like to now introduce the chief moderator and the chief coordinator of today's amazing webinar, Dr. Preeti Kamdar ma'am. She is a glaucoma surgeon from Mumbai. And ma'am is consultant at Dr. Kamdar's Eye Clinic, which is a 100-year-old eye institute, and also at Jesham Eye Institute as well. She's involved in teaching ophthalmology postgraduates for all over the state since last more than 25 years. She has been very active MOS member and MOS also executive committee member. And we have got enriched with by associating with ma'am for last many years. She has organized, conducted, and participated in many CMEs, webinars, and conferences on glaucoma, especially at both national and international scale. She has conducted well appreciated courses on both perimetry and OCT. She is reviewer of many journals, and she has conducted free camps for diabetic patients. She has conducted glaucoma awareness rallies all across Maharashtra as well. So it is our honor and pleasure to welcome Dr. Preeti Kamdar ma'am as the chief moderator for today's webinar. And I'm sure that under her very dynamic moderating session, this is going to be a lot of learning for all of us. Absolutely. So over to you, Dr. Preeti ma'am, to take the show forward. Thank you so much.
Thank you, Vardhaman. Those were a lot of kind words. And let me introduce my speakers who were very kind enough to agree to join and contribute towards this webinar. The first is Dr. Karishma Bhate. She's a glaucoma specialist from Mumbai, and she'll be talking to us on when, where, and why. When do we use the valves or tubes in glaucoma? Second is Pooja Bomaj. She's a glaucoma specialist from Meerut, and she's going to be talking to all of us on how she does MS glaucoma valves. And the third is Dr. Sushil Deshmukh, who's a glaucoma specialist from Mumbai again, and he's going to talk to us on the cheaper version, the poor man's tube, that is the Adi. And all these three are united in one way, and that is their passion for glaucoma. And they are all experienced glaucoma specialists, and there's a lot we will learn from them. So without any further time, I invite Dr. Karishma Bhate to start her talk, please. Karishma, if you can share your presentation. You're muted. Karishma, unmute yourself.
Yeah, am I audible?
Yes, you're audible. You can share your screen now. Put it on now. Yes.
Is it visible now?
Yes, it is visible.
Okay. At the outset, I would like to thank MOS for giving me this opportunity. I'll be talking on glaucoma drainage devices, when, which, and why. So we know that tube implants have been in vogue for over 3 decades since its inception. It has brought a paradigm shift in the way we treat our refractory glaucomas, more so because earlier we didn't have much options other than cyclodestruction. So here comes the indications that patients that have failed trabeculectomy or multiple failed glaucoma surgeries, or patients where we know are at high risk of failure when you do a conventional glaucoma filtration surgery, or secondary glaucomas that are difficult to treat on maximum medical therapy, and we know that they might not do well when you do a trabeculectomy. So giving few examples for the same, patients that have undergone previous incisional conjunctival surgeries, failed traps, pars plana vitrectomy, scleral buckling procedures, silicone oil induced glaucoma. You can see the kind of fibrosis that has occurred after VR surgery. So obviously you cannot make a good bleb over here. Post penetrating keratoplasty when you have glaucomas, or conjunctival diseases which have cicatrization, inflammation, scarring, glaucoma with keratoprosthesis. Secondary glaucomas like the uveitic glaucoma, where you can have pressure spikes because there's an ongoing inflammation or recurrent inflammation despite of good treatment with steroids or steroid sparing medications. Neovascular glaucomas, ice syndrome, pediatric glaucomas that have already undergone trabs and not working, and secondary glaucomas like the iridocorneal dysgenesis, aphakia, aniridia, juvenile rheumatoid arthritis, and Sturge-Weber syndrome. Especially Sturge-Weber syndrome with choroidal hemangiomas, you know that these patients have a better safety profile when you do tubes as compared to traps because of the choroidal effusion and the risk of choroidal hemorrhage. So now we know that in which patients we need to do it, but which valve and when. For this, we need to understand that the what type of shunt we want to use. So I'll speak about the ones that we are commonly using in India and the ones that are available here. So we have the valved shunt, the MOS glaucoma valve, which is around the cost is around 22,000. It has a silicon plate and a silicon tube. So we have two models that we are using, that is FP8 in the pediatric age group, FP7 in the adult age, in the adults. And you can see the surface area is 96 millimeter square and 184 millimeter square respectively. Now, what is the advantage and disadvantage of using an AGV? We need to understand its working. So the MOS glaucoma valve is a valved shunt, and so it gives you an immediate IOP reduction once you place it in the eye. Once you have a good pressure buildup, the valve opens and you have an immediate IOP reduction. Also, because of a smaller surface area, it's easier to place between the recti muscles. Therefore, you don't need to do too much of dissection. The chances of diplopia is less. And because of its valved nature, it minimizes the risk of post-operative hypertony. But because there is an immediate aqueous flow towards the plate of the valve, it is exposed to the inflammatory substances from your aqueous humor, and this leads to bleb encapsulation or bleb fibrosis, and therefore you can have an hypertensive phase in the second or the third week. And this IOP rise we have to control by giving anti-glaucoma medications. Also, because of its smaller surface area of the plate, which acts as a reservoir, that may also provide decreased IOP lowering effect. And sometimes you can have a defective valve mechanism, which is very rare and which can cause hypotony or obstructed outflow. So these are the MOS glaucoma valve models. This is the ones with silicon plates. These are with polypropylene plates, but these are the ones which we are using most commonly. You can see the lower ones. These are the PC7 and PC8. This is used for pars plana implantation. You can see there's an extra clip over here. This is given so that there is no bending of the tube or no kinking of the tube. When do you do a pars plana implantation? When the anterior chamber, when the anatomy of the anterior chamber is highly disorganized, or there is severe scarring near the limbus in a vitrectomized eye, which will not allow you to put the tube in the anterior chamber, or when the corneal endothelial function is compromised, you don't want the tube to be in the anterior chamber. Coming to the next variety, which is the non-valved one, we have the cheaper version, as madam just said, that is the ADI, Orolab Aqueous Drainage Implant, and it is available for rupees 4,000. So you can see there's a wide difference in the cost of an AGV and an ADI. The design is very much similar to the Bearwall non-valved shunt. Here again, the silicon plate, it has a silicon plate, and please note the surface area of the plate is much larger than AGV. It's around 350 millimeter square. Now here, because it is non-valved, when you place it in the eye, the tube needs to be obstructed or ligated with an absorbable suture or via stenting. And therefore, we need to understand that once you place it in the eye, you're not going to have a sudden IOP reduction. And therefore, you will have IOP fluctuations in the post-op period, which needs to be managed with additional interventions or medicines. It will require more follow-up. Also, because the surface area of the plate is more, you need a little more dissection. Surgically, you need to have a little more experience. There could be a risk of diplopia, and if you have not done a proper occlusion of the tube, you can have a risk of hypotony. But because there is not immediate flow of the aqueous to the plate, you have to understand that there will not be much chances of encapsulation of the bleb, and probably that is why you don't get a hypertensive phase here. And these non-valve devices are associated with better IOP control and lower anti-glaucoma medication needs in long term. Another variety is the MOS clear path. Again, it has a silicon plate of 250 millimeter square, or the other model has around 350 millimeter square. The advantages lies in its design. It is low-lying design, natural contour. Fixation eyelets are placed more anteriorly, so it's easier to suture to the sclera, and it has a pre-placed ripcord. So this is the ADI, and this is the MOS clear path path device, you can see the design. So even if it has to be placed under the muscle, it avoids the muscle attachment points. Also, the model 250 is a smaller version and can just be placed in between the two muscles. So which glaucoma drainage device is better, valved or non-valved? So there was a beautiful study done by Dr. Surinder Singh Pandav et al. And they compared the ADI with MOS glaucoma valve, and they found that both the implant had comparable mean IOPs at 3 years with lesser requirement of anti-glaucoma medication in the ADI group. Both the procedures were safe, but with slight preponderance of hypertony related complications in the ADI group. Another meta-analysis also showed that ADI was more effective in both its surgical success rate and reducing IOP and anti-glaucoma medication, and the two implants may have comparable incidences of adverse events. Just a gist of the complications, we know that the principal long-term complication of an anterior chamber drainage device is going to be corneal endothelium decompensation. We know about the hypotony risk in non-valved shunts, but even in AGV, you can get a transient hypotony due to leak around the tube or failure of flow restricting devices. We have already discussed about the hypertensive phase. Apart from that, you can also have tubes that look like this after a few months, where you can have erosions of the overlying conjunctiva, tube extrusions, and infections. Sometimes you may have a longer tube that can touch the endothelium, causing decompensation of the cornea. A shorter tube may sometimes get blocked. Plate migration, tube blocks by iris or vitreous. Apart from that, diplopia, infection, choroidal detachment, a few other things that need to be kept in mind. So how do we select a shunt? I think a general guideline can be followed that for a novice surgeon, valved devices may be preferred because of its ease in putting it in the eye. You just need to place it in one quadrant. And also the post-operative period is more predictable compared to the non-valved shunts. The valved shunts are highly effective for eyes that need low IOP quickly, such as an advanced open-angle glaucoma, uveitic glaucoma, or neovascular glaucoma. But if an eye can tolerate high IOP for a few weeks after surgery, a non-valved implant may be considered. Patient with poor compliance with drug use and follow-ups, valved implants may be preferred due to less follow-ups and post-op care. The amount of conjunctival scarring may also determine what size of implant you want to place. The most important factor influencing the selection of implant is going to be the target IOP, both in short term, which is determined by the kind of shunt you take, whether valved or non-valved, and long term, that depends upon the kind of an encapsulation that you get over the plate. Lastly, it would be cost and the affordability of the patient. So I think no one size fits all. We need to look into the patient's the condition of the eye, what target IOP you're looking at, what is the experience and comfort of the surgeon, and lastly, the cost and affordability. These were just the case scenario which we could probably take up later just for sake of discussion by the panelist. Thank you.
Thank you. That was a very nice and very practical way of setting the tone for the webinar. That was very beautifully said. And now we have Dr. Pooja. She's going to talk to us about how to do MOS glaucoma valves. Pooja, please, if you can share.
Yes. My screen is visible? Presentation is visible?
Yes, it is visible.
Okay. Okay, thank you, MOS, for giving me this opportunity. I'll be talking on tried and tested technique of AGV, MyUV. Basically, we all know that AGV is the surgical technique of choice whenever there is uncontrolled glaucoma and we have already done a trabeculectomy and it has failed. Most of the time, the indications are complicated traumatic glaucoma cases, traumatic aphakia, or post keratoplasty, pediatric glaucoma, as the list has already been enumerated. So, commonly, these are complicated cases. So, we need to select our case very well. We need to do a proper pre-operative examination before going ahead with the surgery as such. What pre-operative considerations we would like to see at? We should look at inspect the conjunctiva area where we would like to place the tube at the shunt. Since there are high chances that the patient has already undergone a previous surgery, previous multiple surgeries, we should be able to identify that part of the conjunctiva which is relatively free and comfortable for us to place the tube. Also check for the signs of neovascularization. If the patient is showing signs of neovascularization due to NVG, then the patient might need an preoperative Avastin. The anterior chamber depth needs to be assessed so that you get the idea like where you would like to place the tube, whether you would like to place it in the AC if the AC is good enough, or in the sulcus if the sulcus is if it is possible for you to place in the sulcus. The tube should be inserted without touching the iris and the cornea. The placement of the tube plays a very important role because the commonest complication that we come across after placing a tube is due to the tube related complication. It is because of the tube touching the cornea or the tube getting exposed. So, doing a gonioscopy to assess the angle is important. The tube may be placed in sulcus in pseudophakic eyes. It is better if placed in sulcus, and you can plan a pars plana placement in aphakic and vitrectomized eyes. If the eye is phakic and the AC is shallow, then maybe you can combine the cataract and tube surgery can be considered. So coming to the surgical technique, it's important that we lower the IOP. Like in all the other glaucoma surgeries, it is important that we have the IOP at the lowest possible pressure so that there is no sudden decompression. We need to give a proper pre-peribulbar anesthesia. Corneal traction suture is desired for proper exposure of the surgical site. The first most important step during doing a surgery, tube surgery, is priming. Priming is important for us to initiate the valve function. The second step is to do a proper exposure. Peribulbar, we do a peritomy. Superotemporal area is preferred between the two muscles, that is superior rectus and the lateral rectus. We don't dissect the rectus muscle for AGV, but it's important to identify that position because it's more comfortable. When you're doing a phonic spaced conjunctival flap, you can create as large conjunctival peritomy as possible. You can give side extensions like this so that placing the implant is easier. Simultaneously, you can create a scleral flap in the same setting if you're not going to use graft. If you have the access to corneal graft, patch graft, scleral patch graft, then it is fine. Otherwise, you can create a scleral flap for placing the tube. The plate is placed at least 8 to 10 millimeters behind the limbus. So we should measure the area 10 millimeters behind the limbus and then place the plate. It is anchored with the help of 10-0 nylon. It is easier if you thread the plate beforehand before placing the tube inside. So once you thread and then place it, it becomes easier for you to anchor it to the sclera. Next most important step is cutting the tube. So you should aim to keep at least 2 to 3 millimeters of the tube inside the anterior chamber. The anterior chamber, and so don't be in hurry in cutting the tube. First assess how much you want inside the AC. If you want to place in the sulcus or in pars plana, maybe you would need a longer tube. So analyze exactly how much is getting left inside and then you cut. A 24 gauge needle is used to enter inside the AC. 2 to 3 millimeters behind the sclerocorneal limbus, the entry should be done and should enter AC above the level of the iris, and the entry should be in the plane of the iris without touching the iris. So those things we should keep in mind while making that entry. So this diagram will show us like how the entry in the sulcus area will be and how it will be above the iris. The last step remains is like suturing the tube with the help of 10-0 nylon. Then the scleral flap with the help of 10-0 nylon, and the conjunctival suturing is done with the help of 8-0 vicryl. The commonest complication that we come across with tubes are tube related complications and the hypertensive phase. So tube related complications can be reduced if the tube is positioned posterior to the Schwalbe's line, and the rate of endothelial loss is also lesser if it is placed more posterior as possible. Longer scleral tunnel and superior entry into the anterior chamber are also associated with lesser tunnel related problems. If the tube is at least 2 millimeters in the sclera before entering in the anterior chamber, it is safer. A short tube inside the AC is desirable, and if the bevel is upside, it is better. And it should be bevel should be down if it's placed in the sulcus. Post-operatively, we should see the tube every time we are seeing the slit lamp examination, so that we come to know whether the tube is open or it is occluded. So visibility of the tube post-operatively is important. So coming to the video, the conjunctival dissection has been done. Corneal suture is taken. After creating the scleral flap, I'm priming the tube. Once the tube is primed, it is placed at least 8 millimeters behind the limbus. It is sutured with the help of 10-0 nylon suture. The plate is anchored to the sclera. It is confirmed that it is at least 8 millimeters behind the limbus. I'm taking the 10-0 nylon suture. The knot is tied. The approximate amount of tube is cut. The anterior chamber is entered with the help of 24 gauge needle. The needle is entered at the level of the just above the iris, in the plane of the iris. It should go parallel to the iris, basically. It should not touch the iris. Also the cornea, you should try to keep the tube as away from the cornea as possible. Then the scleral flap is sutured with 10-0 nylon. If you have corneal graft available, you can put a patch graft above this. And then the cornea conjunctiva sutured with 10-0 vicryl. Post-operatively, antibiotic steroids are given for 2 months, and aqueous suppressants are also added for 4 to 6 weeks. Look for the hypertensive phase. Keep a close follow-up. If you identify hypertensive phase, we should be able to identify and start aqueous suppressants to this patient. It's generally noted in 3 to 4 weeks after this surgery. It happens due to thick tenacious capsule formation. It can easily be managed if you're able to give steroid, increase the frequency of steroids, and also intervene by doing needling. Bleb needling in an hypertensive phase can be helpful. After a trial of aqueous suppressants and steroids, we can do bleb needling to reduce the hypertensive phase. So these are some of the photographs showing the immediate post-operative plate of the valve and after bleb formation. These are some of the post-operative, pre and post-operative photographs of tube surgery after AGV. Thank you.
Thank you, Pooja. That was a very nice presentation and very practical.
Thank you.
And next we have Dr. Sushil Deshmukh. He's going to be talking to us about Adi. Sushil, if you could just please share your screen.
Yes, 1 second, ma'am. Is the presentation visible, madam?
Yes, it is visible.
Okay. Now, first of all, at the offset, I would like to thank MOS and Dr. Preeti Kamdar for the opportunity. Now, my job is mostly half done by the background created by Dr. Karishma and Dr. Pooja. So I will be jumping around a few slides to save time. Now I'm going to discuss mainly about RD, Now, ever since in 1992, Bevel was introduced, and in 1993, AMAT was introduced. Bevel and AMAT, AGV, have ruled the majority shares of the implant world over. Now, Bevel is not available in India, so Bevel gave a permission for the manufacture in India via Orolab. And so we have Orolab aqueous drainage implant, which is RD, which we are going to discuss. It is essentially a non-walled implant, which is with no resistance. So when you deal with glaucoma drainage devices with no resistance, these are glaucoma drainage devices which consist of a silicon tube attached to an end plate and act as a surface for bleb formation. Now, the most important point here is that unless an operation is modified with a ligature or and ripcord technique, these implants are associated with high incidence of overfiltration, and this remains the main problem in the usage of non-walled implants. So this happens secondary to no aqueous outflow resistance, and it can lead to hypotony, shallow to flat anterior chambers, and choroidal effusions. This can be very, very disheartening if we see in the initial surgeries to have a flat anterior chamber with choroidal detachments. Coming to the RD design itself, as described by Karishma earlier, RD is a non-walled tube device based on bare-walled implant. It reduces the intraocular pressure by draining aqueous from anterior chamber to the subconjunctival space formed around the base of the implant. Now you can see this wide wing-shaped plate which measures 350 mm square, and that's why you get a good low IOP control. I'll directly go to the surgery, and so we start by marking the incision. I tend to start 2 millimeters behind the limbus so as to get a good posterior exposure. Once the conjunctiva is exposed, now we identify the muscle and dissect the underbelly of the muscle, both the superior and the lateral rectus. I prefer to use the superior temporal quadrant. The tube is primed in the similar way that we prime the AGV. And now we are inserting a 50 proline into the tube from the back side, which will work as a ripcord. Now the tube is ready, and so we insert the wings of the tube under the superior rectus first. Here the assistant role is very important, and they need to be well trained how to assist and how to give us a good exposure. The same way, the other wing is tucked under the lateral rectus. And once the tube is placed, we just pull and see that it is well secured and it doesn't move. Now anchoring of the plate is in the similar manner. I tend to use 8O nylon. Both the eyelets on either side are used to anchor the plate nicely to the sclera. And once the anchoring is done, then we go to the insertion of the tube. Before we plan the insertion, we mark an anchoring tunnel and an entry site. You can also note at a good exposure which can be achieved by a specially made eye speculum which is available from Epsilon. Gives a good wide exposure and a surgical site. Now the suture is being ligated with 70 proline, 70 vicryl from outside. It's better that we use fingers to have a good tight knot, and then we check by again pushing BSS saline and see that it is completely occluded. The tube is cut. I tend to keep around 2.5 mm into the AC and around 3 mm in the sulcus. This tunnel is created for anchoring the tube onto the sclera, and now the entry site. I tend to start 3 mm behind the limbus, make a tunnel. This is a pseudophakic eye, so as discussed, sulcus placement is preferred. The 24 gauge needle mounted on a visco creates the tunnel, and then we inflate the AC with the visco. This gives us a good formed eye to insert the soft silicone tube. This soft silicone tube is very, very flexible and it is sometimes difficult to insert. Once it is inserted, we anchor the tube to the sclera with additional suture. And if the entry is loose, we can take a suture there as well. Once all of this procedure is done, we do the stenting slits, venting slits, 2 to 3, depending upon the case. Now the case is almost done and the conjunctivas are opposed. Before doing that, we need to place the ripcord into the lateral aspect of the conjunctiva, which can be accessed on a slit lamp or even in the OT. The removal of the ripcord, depending upon the surgeon's comfort, can be done in the OT or in the on the slit lamp as well. Now the extra part of this 50 prolin is cut and the free end is positioned below the conjunctival pocket that we have created. So we can see a tip of the suture there. The traction suture is removed and the vicryl is used to suture the conjunctiva nicely. So that's about the video. The indications and the other aspects are well covered of all the tube. So I'll just go through a few contraindications and few specific complications. Contraindications here would be extremely fiable thin conjunctiva, pre-existing scleral melts and scleral diseases. Borderline corneal endothelial function is a relative contraindication, as if we note that we can always place the tube in a sulcus in case of a pseudophakic eye or a pars plana approach in a vitrectomized eye. Now, advantages of RD is that effective in long-term IOP reduction even after failed tuberculectomies with MMC, most likely to survive future intraocular surgeries like PKP or lensectomies or vitrectomies. Therefore, best drainage option in these circumstances. And like any other implant like AGV, even RD is compatible with the contact lens wear. Disadvantages are, yes, it is a non-walled implant and hence there could be higher complication rates, especially in the beginning curve of surgical learning. Longest rehabilitation period if the tube is totally occluded with extraluminal ligature and an intraluminal ripcord. It needs competent, accessible vitreoretinal surgeon in case you're planning a pars plana placed tube, because if the peripheral base of the vitreous is not shaved off completely by inducing a complete PVD, that remaining base of the vitreous could block the tube. Now coming to complications, a few intraoperative complications, oversized anterior chamber entry incision, it could leak and lead to disastrous flat AC in the post-op. So if we note that, we would close it with extra sutures. Improper direction of entry, we can always remove it and close the entry and create a new entry on the lateral side. Scleral perforations are rare, but if they happen, it has to be dealt by doing a retinal cryopexy. Anterior chamber tube cut, if it is cut short, then you have no other option but to either use a tube extender or you can use a backup spare implant. Early post-operative, that is within 3 months, the most important in non-walled implant is the hypotony, and it can be avoided by either having a ligature and a ripcord, or also you can plan a 2-stage procedure, which is not very common. Now with the ripcord and the ligature, the outcomes are pretty much consistent. Inflammation has been discussed and the steroids can be a role there. Tube blockage by iris, pigment, or a strand can be done by YAG laser lysis of the debris. A cannular flush can be done in the OT to clear out the debris into the plate. And vitrectomy if there is a vitreous strand obstructing the lumen. Late complication, again, hypotony. This happens when the tube opens up, when the external ligature gives way. And so if there is a persistent hypotony not responding to your medical management, then you will have to go in and do a tube ligature, or in rare cases, nothing works, you can remove the implant. In case of tube migration, surgical revision may be required. And in case of an implant erosion or an exposure, we will need to cover the leak defect with a tissue graft, either a scleral or a corneal partial thickness graft can be used. In case of corneal decompensation, as already discussed, we need to either snip the tube if it is too long and coming close to the cornea, or you can reposit it into a sulcus or a pars plana depending upon the case. Endophthalmitis is treated and taken care of as with any other infection. And diplopia, yes, diplopias are commoner in non-walled implant as the wings of the plate goes and sits below the muscles. So mild diplopias can be dealt with by prisms, and if it is intractable diplopias affecting the quality of vision of the patient, it could require a removal of implant. So this is one thing which has to be dealt with very, very meticulously and cautiously, is to avoid intra or early post-operative hypotony. So we use a long snug tunnel incision, which is created by using a 24 gauge needle as we saw in the video. And usually 24 gauge is adequate because the sclera is slightly elastic and it will be sufficient for the insertion of the tube. Intraluminal ripcord using a 5O non-absorbable suture, I prefer a 5O Prolene, and an extraluminal ligature with a 7O Vicryl is very, very good to prevent a early postoperative hypotony. Now, when you do this, there is virtually not going to be any filtration. So you need to do a venting Sherwood slits anterior to the suture. So you can do 2 to 3 venting slits, which would suffice for the initial 4 to 6 weeks. By then, the ligature should give way and it will start filtering more. Two-stage implantation, as we discussed, is a little rare, but if we are planning, we have to implant the plate earlier, let the capsule around the plate mature, and then implant the tube into the AC. Hypertensive phase has been dealt well, so I will not dwell too much. The point has been well taken up that the non-walled implant, the hypertensive phase is significantly lesser. The early hypotensive phase, you can see there are multiple dilated conjunctival vessels around, and they could be associated with hypotony. Stable phase will give a nice large bleb around the plate, and it is very satisfying to have a good bleb posteriorly placed, which assures you a long-term IOP control. So in conclusion, it would be prudent to say that AGV is easy to insert, has less dissection, requires lesser intraoperative time as compared to other glaucoma drainage devices, and has low incidence of hypotony. AGV also has higher incidence of hypertensive phases, and that might require additional medications and needling. Implant is ideal. AGV implant is ideal for patients with diseases presenting with very high IOP, and they require very early control of IOP, like NVG, PKP glaucomas, glaucomas following retinal detachment of epiglaucomas or uveitic glaucomas. Whereas RD appears to exhibit a lower incidence of hypertensive phase and may achieve lower IOP. RD implant requires more extensive dissection and experience of handling rectus muscles, additional operative time, and use of strategies to avoid postoperative hypotony, basically the external ligature and the ripcord. Large surface area of this end plate results in larger blebs and lower IOPs and gives a very good long-term control of pressure control. Thank you.
Thank you, Sushil. That was a very nice presentation and a very detailed one. So now we can have the panel discussion, and Dr. Atul Kadhane, he is a very dynamic secretary of Maharashtra Ophthalmic Society. He will introduce the panelists to us. So Dr. Atul, if you could just...
Yeah, thank you, madam. We have today Dr. Sharmila Reddy from Madurai. Madam is a senior consultant at Arvind Eye Hospital. We all know the hospital, and she had been a national faculty and a tremendous work in the glaucoma drainage device. Is a teacher for so many glaucoma consultants at present also. Another finalist with us is Dr. Rita Dhamankar, our own MOS faculty. Madam is a glaucoma consultant at Lakshmi Eye Institute. She is amongst the first two who started the selective laser trabeculoplasty in India. She's been a PG teacher since last 17 years. And besides, she had an interest in the field of medicine, education, and research also. The other faculty is Dr. Mandar Paranspe, our treasurer MOS. He is at present the president Pune Ophthalmic Society. a comprehensive ophthalmologist with inclination towards glaucoma. And the fourth is me. I'm Dr. Atul Kadane. I'm a comprehensive ophthalmologist, and I always fond of learning new things. So maybe this after this webinar, maybe I am thinking of I may start doing the glaucoma drainage devices in my practice also. So over to you, ma'am.
Yes. Thank you, Dr. Atul. And Rita, if you could just please unmute yourself. Dr. Sharmila, if you could unmute yourself.
Yes.
Of course, and our speakers and Dr. Mandar. So I would start with Dr. Sharmila.
Yes.
You have been training so many people, right? Like
True.
you train PG. So now today we have comprehensive ophthalmologists and PGs who want to start doing it. So what is the type of patient they should select? That is first implant, and which implant, and how do they select the patient?
So I think the first speaker, she covered very well about the patient selection and what kind of implant has to be chosen for which kind of patient. So if you just, to answer your question to somebody who's going to be beginning to do, I think, it is a little complex to identify the muscle dissection. That is a kind of like the difficult step when you do a transition from trabeculectomy and go towards tubes. The most difficult step is to identify the muscle, because oftentimes we tend to people tend to get confused with the tenons. Sometimes even a thicker tenons may be assumed like it is the muscle. So that is with the complexity involved with the non-valve devices. So if it was a beginner, I think if you have an access towards like the AGV, the valve devices are better because it doesn't involve much of conjunctival dissection. It doesn't involve the dissection of the muscle, and it's relatively simple because you can just make a pocket and just it's a smaller device. You can just fit it inside, and then the rest of the steps, of course, are similar to both the devices. So what we generally do in our hospital is we have some wet lab training. So we do have these goat's eye, although we do not have a real feel as what we do on the human eyes. However, it does help in a few of the steps. Very importantly, like the fixing the tube to the sclera, or cutting the tube and trying to make a track into the eye to allow the facilitate the tube entry. And muscle, of course, you cannot have a muscle. So basically, the rest of the steps, like how much of sclera has to be taken to do the suturing. So all of those steps we kind of tend to prime them in the wet lab itself. And then to start off, I think for a beginner, the valve devices will be a lot better and easier to do it. But if you have a support of a squint surgeon, if it is a facility where there is a squint surgeon who's around and they are willing to assist you in the initial few cases to identify the muscle, and then you cross check with them that it is the muscle, and then you identify, you understand the anatomy, then I think once you master that, then I think both of it are easier to do.
Thank you. Rita, what kind of patient? Now, Dr. Sharmila has very clearly said that AGV is easier to do, and at least to get a feel of the valve, do it on both sides. Like how you will handle the valve, how you suture it, that kind of make a track. So which patient would you select? Phakic, aphakic? So for the beginner, the first case of an implant for a comprehensive ophthalmologist, what patient will you select? Because you also train residents, that's why I'm asking you.
I would be very happy to have a patient who's got a good corneal endothelium. That will be my first concern when I'm giving the first case to my resident to do. Of course, after adequate wet lab training, you cannot, start a resident or a fellow directly onto the patient without any wet lab training. However good cataract surgeons they may be, you still have to let them, get the feel of how deep to go, where to make the opening, how to make your opening of the tube just enough for the tube to go in and not let leaks happen after that. And then how, after you have made that entry with the tube, there is a little trick that I teach my residents is that you just come out with your 24 gauge needle and hold the upper edge. So then putting in the tube and inject visco. and putting in the tube from that thing makes the entry of the tube very easy. So these are little things that I look at before I let my students actually take on a case by themselves. Another thing that I also make sure is that I normally don't give them neovascular glaucomas and stuff like that. I prefer if it is a phakic eye with good corneal endothelium, if I have a choice. But very rarely you have a choice when you want when you want to give residents cases to do, because we have to really search for cases for them to do. But yes, if you ask me what would be my preferred case, I would be very happy with a nice deep anterior chamber and with good corneal endothelium. So then there is very little chance for them to go any other way, because then their tube is absolutely parallel to the iris. It doesn't touch the endothelium, it doesn't lie down on the iris, and you are in your comfort zone letting them do what they're doing.
So it has to be preferably, so
Okay.
as AGV. Second is wet lab training is mandatory.
Absolutely.
You directly cannot do it on a patient. That's for a person who wants to start it. Take a patient with a deep anterior chamber. A pseudophakic eye would be preferable. And neovascular glaucoma, what happens? There is peripheral anterior synechiae. So even though the anterior chamber looks deep, your tube may have obstruction. So these are the and preferably superotemporal quadrant with no retinal hardware. So these are the patients which you should first select. Now, Pooja, when you first started doing tube, or rather, I'll go to Dr. Atul and ask him that, Dr. Atul, you want to start doing tubes. So what would you expect? What are the things that you think you will have a difficulty with?
Basically, the first thing, maybe as a comprehensive ophthalmologist, many times we feel we are used to do a trabeculectomy, but the madam pointed out is the muscle handling part, because whatever video we saw, there is some sort of there is a hindrance there, because we are not, maybe at least I'm not used to handle the muscles, because I didn't do any sort of training in a squint or something like that. I'm good in cataract. That is one thing which always I thought whether before going for a tube or something like that. And the second thing is the this, it may needs a learning curve, we feel. So I thought that is another point which is keeping away from the tube. And the third is key, if at all, if I have to choose the case, the madam had given the answer that it has to be in what case should I start? It should be an aphakic glaucoma, or maybe that way. Maybe we are in a safe zone for the first case to start with. And the wet lab training, surely, as she had pointed out, maybe I can, before I touch, I will think of this. Maybe in some conference, in glaucoma conference, you may offer such sort of training at the SSTC or something like that.
Yeah, Glaucoma Society of India and both AIOC, there is a wet lab for tubes. So
Okay.
that is mandatory, one thing. Now, let me ask Dr. Pooja, when you started doing tubes, what are the problems that you faced?
Yeah, when we started tube, main problem is the cost. Because that at least in my scenario in the rural background, patients, when you tell the cost of AGV as such, cost was the major reason why I had delay in starting the tube surgeries. Um, but once you are able to explain to them the importance and the reason why you need to undergo the tube surgery, then you can maybe counsel the patient and tell the importance and start doing tube surgeries, especially AGV. And in that,
The financial is yes.
Yeah.
Surgically, what was the rate limiting step? I mean, when did you stumble when you first started?
Surgically, basically, I always felt that I should start one poor prognosis case, because explaining the results to the patient was a major thing. Uh, Adi, as AGV basically is pretty easy. No specific contraindication or difficulty. You generally don't face any difficulty when you want to straight away go and do that tube. just the more dissection that is needed compared to trab. More dissection is needed. Your entry inside the AC has to be more careful. You should not be damaging the endothelium. I think the entry inside the AC and placing the tube in the right manner inside the AC is more challenging in tube surgeries compared to the other trabs and all that, because most of the time they are already undergone some surgeries. So superior limbus is already damaged or some handled. So finding the bare proper area is a challenge. I think that is the major thing that you should be looking at when you're learning.
Okay. Thank you, Pooja. Mandar, if you can just please unmute yourself. Yeah. So you have, when you started, any special instrumentation that you thought of before, like cataract? Everybody has a cataract set. So is there anything separate from a cataract set that you would want in a when you do a tube?
No, there is no special instruments that I thought of while starting the AGVs. I have never done an RD implant. So the only thing which I would like to add to what has already been very well elucidated is initially sometimes your dissection, scleral dissection may be superficial, and then there is always the risk of tube exposure. So this is one lesson which I learned, that I always keep a scleral patch graft ready in the OT, so that if I feel the tube in the initial few surgeries, if there is a chance of tube exposure, then it is always better to cover the tube with a scleral patch graft, because ultimately that also decides the success or failure of the surgery. And as was told by Dr. Pooja, you have to learn to angle your needle properly, so that it goes parallel to the iris. One particular difficulty which sometimes I did notice was, if the cornea is a bit hazy, then sometimes visualization of the needle sometimes becomes a little difficult, particularly if it is in the superior temporal quadrant. And one small trick which I do is I use a light pipe from the other side, either from outside or from sometimes intracameral, and that sort of makes the anterior chamber a little more clearer. So this is in the at least in the initial few surgeries, or even when the cornea is not very good or is not very clear. So apart from that, of course, all the routine instruments that one needs for cataract surgery is good enough for doing this. And one more thing which I would like to add is that the conjunctiva needs to be assessed preoperatively absolutely perfectly, because sometimes you realize intraoperative that the conjunctival dissection, because of previous surgeries, is difficult because it is tethered or it is scarred, and then it sort of shreds sometime. And then when you get this kind of a conjunctival dissection, then covering the tube with the conjunctiva then becomes a big problem. So it is always better to assess the status of the conjunctiva in the sector that you are going to do the place this thing, which is most commonly the superior temporal quadrant.
Thank you, Mandar. Those were very useful tips. And Dr. Sushil, you have been modifying the Adi, to avoid that extensive dissection. So could you just share that with the audience?
Yes, I have tried to search for the video, could not, but I'll share the technique. This is particularly in cases where you don't want extensive dissection, or the pressures are on a slightly higher side and you do not want to wait for too long to get the ligature absorbed. What I do is I cut the flanges on both the sides, and the size of the implant is slightly bigger than what a AGV is. That is because the anterior part of the RD is also slightly larger, so it will be slightly more bigger than AGV. And then you need not to dissect the muscle. You just need to open up the conjunctiva like you do for AGV, ligate the tube, anchor the tube, and then enter the ligate the plate, anchor the ligate the tube, anchor the plate, and then enter the AC, like similar to the AGV. Only additional step there would be ligature of the tube. So because the area is smaller, when the ligature opens up, most of the time the hypotony is not so aggressive, and you can get away by just doing an external ligature, and depending upon the case need, you may add it with a ripcord or may not add it with a ripcord.
Okay, so you
So
can
you-
do away without the.
Yeah, but when I don't put a ripcord, I do ligature with two ligatures, one next to each other.
Okay.
So
And
that's only to be done when you have sufficient numbers under your belt, because this can be disastrous when you just do a ligature and don't do a ripcord. It can land up into severe hypotony in the early postoperative period. So that's not my advice to any beginner to attempt that. Only once you are sufficiently comfortable with AGV and you have at least 15 to 20 RDs under the muscle with you, then you can attempt to do this. This technique was learned by me when I was in Arvind, and I have seen Dr. Ganesh Raman and Dr. P. Satyan, who are my mentors, doing this and guiding us on this. So what happened, this was particularly in case where there has been a scleral buckle placed, the muscles have been this thing, there is too much of scarring over there, and you cannot place such a big RD below the muscle. Then in that case, you can use this modification, trim it, make it small, and use it like an AGB.
It doesn't, the cut edges are not sharp. They won't, because otherwise it's a very smooth implant.
Yeah, it's a very smooth material. It's so smooth. The tube is also so flexible that insertion of a RD tube is slightly more difficult than insertion of an AGV tube. Similarly, the plate is also very flexible and very soft.
The cut edges are not sharp enough to erode
cut edges are not sharp. Cut edges are not sharp, and they don't, because the plate is basically lying much posteriorly and well covered with the conjunctiva. There, the friction and the chances of friction causing exposure of the tube is much lesser. So most of the tube exposure happens in between the area of 2 millimeters to 6 millimeters behind the limbus, wherein the lid friction, whenever there is a blinking of the eyelids, happen.
Thank you. Karishma, now if there is retinal, many of the times there are these secondary glaucomas intractable and they have undergone a retinal surgery. More important, I mean, vitrectomies are fine because there is no retinal implant. So if there is a buckle, or how do you proceed? How would you still use, or which quadrant would you use? How would you go ahead?
Yeah, I've not done one AGVs with a buckle. I think the seniors would be more comfortable to answer that question.
Yeah. So, Dr. Sharmila, if you could answer that question, that if there is, do you remove it or do you choose a separate quadrant? What would you do?
Ideally, we'll first look at whether it is a 360-degree buckle or what quadrant they have used. And then you first inspect the conjunctiva, number one, you see how much of it is scarred. And then there is a capsule that forms around the buckle. So basically, kind of we open up the capsule and we clear out all the fibrous capsular reaction, that is capsule that is covering the buckle. We free out that, and then either you make enough room and then you place the implant over the buckle or under the buckle, depending upon how much you're able to dissect the tissues around the buckle. So if you're getting a good amount of dissection, then under the buckle, you can still push it under the buckle. But if it is difficult to access the fibrous capsule there, then you might place it over the buckle.
There will be so much space. Do you ever remove the buckle or you don't?
Sometimes we might have to just cut out that bit of the segment to facilitate the placement of the implant, because it is sometimes very, very difficult, because these eyes are all scarred and they have very thin conjunctiva. It becomes difficult to even the closure becomes difficult later. Even if you're able to make an opening later, you have to reposit back the conjunctiva. That becomes very difficult. So in such cases, we would just cut that particular segment in which quadrant you're going to plan for the implant, and then place it, and then always ensure that there is a good conjunctival coverage. So I will try to pull up the conjunctiva as much as possible to see how much of it is getting opposed closer to the limbus. So that will be one other key step that I would follow even before finishing up the plate fixation and all that. Once the plate is fixed, then I'd always try to mobilize the conjunctiva to see how much closer to the limbus that I will be able to suture this, because ultimately you need a good coverage about the tube and the plate. You don't want to have any tube erosions or plate exposures.
Ma'am, I have one query regarding this buckle. If the cause of the glaucoma is buckle itself, can we release that buckle and put the implant below that?
If the cause of the glaucoma is the buckle itself, you mean to say that there is a tight buckle that is causing high intraocular pressure? In that case, yes, but then we always have to take a retina colleague's opinion, because you cannot just remove something. The purpose of it has to be like
already purpose has been served.
Yes, but we do not know how many months since. I mean, we have to calculate like when was the last buccal surgery and when is this surgery. Like, what is the duration between the two, and whether it is fair enough to do that surgery. So it's better to get a retina opinion and then plan for a removal as such.
Dr. Agarwal,
nowadays, I think, on having said that, I'm sorry, and having said that, I think the number of buckles are becoming very less these days. We don't see it as much as it used to be.
No. Dr. Agrawal himself is a retinal surgeon.
Okay.
And that's how he's asking the question.
One more question I have in mind. If it is a silicon filled eye, how you implant means it?
Yes, that's a very good question. Basically, silicon filled eyes, again, generally we tend to, you plan for a silicon oil removal, and that is what we do. But sometimes, depending upon the disc damage, we do not just do only the silicon oil removal. If in case the so-and-so patient has a very advanced cupping with a very high intraocular pressure, just removing the oil might not really help, because you know that even after removing the oil, there are a lot of these small, minute droplets which are still persistent. You might not be able to get a complete removal of the oil, which means that there is always a risk of high intraocular pressure in these eyes, with all of these small globules going and obstructing the TA. So in such cases, we prefer to do a combined the tube with the silicone oil removal. And when you're going to do the silicone oil removal, anyway, you're going to go into the vitreous cavity. So I prefer to place the tube in the vitreous cavity. And whenever we place the tube in the vitreous cavity, it is usually a longer tube. We don't want the tube to be smaller, so it has to be much longer than what we do in the anterior chamber. If it's going to be 2 millimeters in the anterior chamber, it can be like 4 millimeters in the vitreous cavity.
Okay. Thank you. That was a very nice discussion we had, and it was at 1 hour. We have overshot by 10 minutes. So what I'm going to do is I'm going to summarize it for the comprehensive ophthalmologist. That,
Madam,
yes?
before that, 2-3 questions I have in mind.
Of
that
course,
is practical
please.
Questions, because
Yes.
I am also not doing GDD, so I have to also, like Atul, I also plan to start it. So
you'll be able to do it faster because you are very good at exposure.
Just like a rapid fire round. Is there any role of mitomycin in your these surgeries?
Dr. Rita, if you could answer that question.
So the thing is that I don't routinely use mitomycin at all, but sometimes after a AGV has been done and the bleb, the plate gets capsulated very quickly, and we need to needle and open out the bleb that is formed. Then I sometimes use mitomycin afterwards, not on the table itself. While I'm needling, I then use mitomycin in the neighboring area, so as to diminish the fibrosis, because we know that the inflammatory mediators are still going to be coming, and fibrosis is going to be an ongoing process for some time more. So for that little period, so that you don't get fibrosis and you get a nice big area of drainage, that is what I do. But I don't use it routinely when doing the surgery itself.
In aphakic cases, do you go for antravitrectomy before doing the implant?
No, not at all.
Not required, because vitreous strands can
unless you see that there is vitreous in the anterior chamber which is causing the secondary glaucoma, then of course you can you can do a small anterior vitrectomy. But normally in aphakic cases, it's not necessary that they're left aphakic only because there is vitreous in the eye. And I think nowadays we don't see too much of aphakia. We see more. I mean, when I said aphakic, I meant to say deep anterior chamber, so which means pseudophakic eyes.
And for left eye surgeries, you want to implant superotemporally. So would you like to sit on the head end or the temporal end side?
We are very
To
comfortable
do
sitting
the
at the head end.
dissection.
We are very comfortable sitting at the head end and doing both right and left superotemporal. It's not very difficult.
Okay. Okay. Yeah.
Any other questions?
No, nothing, ma'am. Thank you so much.
There's one little tip that I would like to share is when you get, because you get exposure, I think what Mandar said was very right, that it is always good to keep a scleral patch graft if possible on the side. And secondly, because you can get a tube retraction sometimes because we are talking about putting a 2 mm tube in the anterior chamber, you can actually have a longer tube and make a sinuous turn of that tube outside on the sclera where you anchor it to the sclera, so that if by any chance there is a retraction that has happened, you have got a long tube, so you can snip off the tube that has come out and still you have an adequate tube, so you don't have to use tube extenders and stuff, so that it sort of lessens your complications afterwards.
I second that. What Dr. Rita just told. Usually, even if I say that it's 2 mm of tube is in the anterior chamber, actually I make the synovus course so that later for retractions you can just. A lot of children when they undergo these surgeries, they have a lot of retractions. So then you can just do a tube repositioning by directing the tube in another direction, and you will have enough of tube in the AC.
One dilemma which often I feel is in these patients, how long should you continue steroids post-operatively?
Karishma, you want to take that question, please?
Yeah, so we would at least continue it for 6 weeks to 2 months in tapering doses.
I would think that I would be very happy to keep it on for until 6 months in very, very minimum doses. I would not stop my steroids so quickly in 2 months. I would like my patients to be, because you don't want that inflammation to be there at any point in time. Those inflammatory reactors are actually the ones that give rise to all your failures later on. So I prefer to keep my steroids on for a longer time.
And now we have even the soft.
Sorry.
Yeah, now we have the softer steroids also, which have less chance of steroid-induced IOP rise.
That's right.
So I think those are quite effective instead of giving the Pred and Dexa and all those.
So I think I'll just summarize that for the comprehensive ophthalmologist, if you want to start tubes, first is you have to attend a wet lab or get a feel of the implant, how to suture it, how to handle the tubes. That is one. How to make a tract. That is one. Second is, if you have a colleague who can come and help you, that will be really nice. And colleagues are always there to help. Second, use an AGV, that is easier, and do it in a patient who has in a superotemporal quadrant, who has a deep anterior chamber. And the surgical techniques were very well documented by Pooja and Dr. Sushil and Karishma. She gave a very good overview of when you should use tubes. So that I'm not really going into again. Now the tubes can be put in the sulcus, they can be put in the pars plana, they can be put in the anterior chamber. For a beginner, anterior chamber is easier, and that's why do not select neovascular glaucoma as your first case. And after that, yes, post-operative care is a little different for the two. AGV does not have a very stormy course, whereas you can have a little stormy course with the ADI. But one thing is that there are no gains without pains. So you take more pains for ADI and you get a lower IOP with ADI. Whereas with AGV, it's relatively easy, but the resultant, the final IOP is a little on the higher side. So that is what helps you decide which one to use, and apart from the cost. But for the first two, you can keep the cost aside and start learning, and then your finances will come into the picture. So thank you all, my panelists and the speakers. And now I give it over to Dr. Aditi and Dr. Vardhaman.
Yeah. Thank you so much, Dr. Preeti ma'am. I think it was really nice, and you made sure that it was in the tune for comprehensive ophthalmologists. So I think a lot of comprehensive ophthalmologists had a lot of take-home messages and very nicely summarized also at the end. So of course, we thank everyone, but I would like to now invite Dr. Aditi, who is the Secretary of Scientific Committee, to officially give the vote of thanks. And just before that, I would like to ask our President, Dr. Agarwal sir, to give a concluding remark, and immediately after that, Dr. Aditi will speak. Over to you, Dr. Agarwal. Yeah.
Yeah, thank you, Vardhaman. Thank you, Preeti ma'am. She has taken a lot of efforts for this webinar, and I think all the our viewers and our members will get idea how to start this surgery, new modality of treatment. Many of us are not knowing till now, including me. So now we got the chance to learn, and the one more thing I got that in MOS conference also we'll keep wet lab on this tube also. So Priti Kamdar madam has one more work to do for MOS. So thank you so much, all the speakers and panelists for a very fruitful discussion. And thank you, Vardhaman, also, and Aditi for assisting in making this webinar. Thank you so much.
Thank you, sir. And now I will request Aditi to give official vote of thanks, please.
So I would like to thank the speakers, Dr. Karishma, Dr. Pooja Bhumaj madam, Dr. Sushil for extremely good presentations. They really made the concepts clear even for non-glaucoma people or even comprehensive ophthalmologists. Even the surgeries which they did appeared like even doing valves is simpler from their videos. I'm sure they are not, but their videos look like that. So thank you, Dr. Sharmila madam, our national faculty. It was really nice to have you here with us for the MOS webinar. I would like to thank our own MOS faculty panelists, Dr. Rita Dhamankar madam, Dr. Kadhane sir, Dr. Paranspe sir for making the session interactive and for their contributions in making the concepts clear. Thank you, Dr. Preeti Kamdar madam, for planning and running the whole show. Thank you to our President, Sir Dr. Agrawal, Sir, and Chairman Scientific Committee, Dr. Vardhaman. I would also like to thank entire team as well as the technical team for making the presentation glitchless. And thank you all the viewers who have joined us on various platforms. Thank you once again from Team MOS and Scientific Committee.
Thank you. Thank you, Aditi.
Bye-bye. Good night.
Thank you.
Good night.
Thank
Good
you.
night.
Good night. Good night,
Dr.
everyone.
Sharmila.
Thank you.
Bye.
Thank you for
Bye-bye. Good
joining
Thank you
night.
so
today.
much. Bye.
Good night.
Bye.
Good night.
Bye.
Thank you.
Thank you,
Good night.
especially Preeti ma'am. It's a lot of efforts, and I love the way you moderate always. It is
Yes,
always
yes.
enjoyable.
Thank you.
Absolutely, yes.
Thank you so
Yes,
much.
that,
Bye-bye.
that we
Thank
should
you.
admit. Yeah.
Yes.
Yeah.
Thank you.
Bye.
Thank you. Bye.